Good afternoon, St. Rose family, administrators, faculty, staff and students, guests and friends of the college. Greetings. I am Leroy Bynum, Dean of the School of Arts and Humanities, and on behalf of our president, Carolyn Stefanko, who unfortunately could not be with us this afternoon, it is my great honor to welcome you to this, the third annual William Randolph Hearst Lecture on Innovation in Communications. The purpose of the lecture, which really is an interactive conversation, is to bring together leaders from the Hearst Corporation, members of the St. Rose community, and the public to discuss how the breakneck pace of change in communications and information affects our lives. The lectures are a result of the partnership between St. Rose and the Hearst Corporation and its local newspaper, the Times-Union, which dates back to 1966. As part of that partnership, St. Rose trustee and Times-Union publisher George R. Hearst, who is with us today, and the Hearst Foundation have made continuous efforts to recognize the importance of investing in students. More than $165,000 has been awarded to multicultural students through the Hearst Foundation endowed scholarships, the Neil Hellman Library, the Mastery Center for the Arts, and the William Randolph Hearst Center for Communications and Interactive Media all have benefited from the generosity of the Hearst Foundations. Ladies and gentlemen and friends, it is my pleasure to introduce you this evening, to introduce George Hearst, who will in turn introduce and welcome our speakers. Thank you. Thank you, sir.
Good afternoon, everyone. It's good to be here. My day job is publisher of the Times-Union. And the Times-Union dates its roots back to 1856. It has been a Hearst newspaper since 1924, and the tradition of great journalism continues in the pages and the digital frames of the Times-Union. And it's great to be here. I also wear the hat as a trustee of the College of St. Rose, so in the form of full disclosure, it's important that you know that. I'm a little bit conflicted in the things we do across the community. But Dean, thank you very much for that very kind and generous introduction. We do have a long-standing relationship with the college. Our Multicultural Student Scholarship Fund has really moved the needle. When we established the fund, first-year student enrollment, people of color, was just at around 4%. And if Mary Grondal was here, who's the Vice President for Enrollment Management, she would report a very strong, closing in on 30%. So the consequences of our funding have been significantly enhancing the quality of the enrollment of the student body here at the college. We also were able to participate in the Mastery Center for the Arts with the William Randolph Hearst rehearsal studios, and not to be outdone, the old music building allowed us to repurpose that space into the Communication Center for Interactive Media, donning the name of William Randolph Hearst. And so it gives me great personal pride, both as a member of the Board of Trustees at the college, a member of our community, and certainly a member of the Hearst family, that the traditions continue. Although this is the third annual lecture, in the lecture series of William Randolph Hearst name, it's actually the fourth event that we've hosted here at the college. The first one being that of Eve Burton, which is the General Counsel of the Hearst Corporation. She spoke on First Amendment issues in cyberspace, kind of a whole new set of considerations. She was followed by George Kliakoff, who's our co-president of Hearst Entertainment Syndication. He talked about the evolution of entertainment and how it plays in a digital and very social world. And then he was followed by Phil Weiser, who's the Chief Technology Officer for the Hearst Corporation, who came down here early in the day and met with the students and had him fully convinced that in the few short years ahead, we would all be Borgs, some hybrid between machine and human. And then he came up here and sat next to Rex Smith, and they talked about items such as Google Glass and underskin implants with smart probes that would keep you healthy running through your bloodstream, kind of a future state. So today, we continue the tradition, and we have with us Dr. Gregory Dorn, who is the president of our Hearst Health. And to introduce Greg is my editor, your editor of the Times-Union, Rex Smith. Rex, who came to the Times-Union through the Troy Record, has been now the longest tenured editor within the Hearst newspaper company. And so with great humility, I know Rex will like to come up here and take a bow. Yes.
Uh-oh. Thank you. Well, that's a wonderful thing. Who knew? Thank you. I always say it's a great thing to work for George Hearst because you get a sense, even in the tumult of the digital transactions, the digital revolution that we're a part of, you get a sense of possibility. And so excuse me just a moment while I turn on my beneath the skin implant here and to record all of this. So we've got this all figured out. I'm just here basically first to introduce our guest. After he speaks for a while, we'll have a little bit of conversation, then we'll bring up a panel that will give some professional, learned responses to what's going on here. Dr. Gregory Dorn has, since 2013, been the president of Hearst Health and the executive vice president of Hearst Business Media. Now, just so you'll know what this is, in case you don't recognize the logos that are up there in the top of the screen, the mission of Hearst Health really is to guide our care moments by delivering information into the hands of everyone who touches a person's health journey. And it's remarkably successful at that. Let me just give you a couple of statistics. Each year in the U.S., care guidance from Hearst Health reaches 84% of discharged patients from hospitals, 174 million individuals, 35 million home health visits, and 4 billion prescriptions. You know those little printouts when you get a prescription that tell you about drug interactions and so on? That's Hearst. So that's a great thing, isn't it? From the standpoint of someone who works for the Hearst Corporation, it is indeed. So some personal information about Greg. Greg's undergraduate degree is from Columbia University School of Engineering. In college, he was on the varsity lightweight crew team, go Lions. And his MD also came from Columbia. And then he went out to UCLA for a master's in public health. The academics in the audience here, I like to say this when we're on a college campus, would like to know that he has published in many peer-reviewed publications. I checked the titles. They are too obscure for me to understand. But I do say that his focus in his work is on improving health care through evidence-based point-of-care clinical decision support. And he will explain that to you. So I'm very proud to be a part of Hearst, which is one of the world's most diversified media and information companies. And I'm proud to be able to present to you one of the great creative minds of our company, Dr. Gregory Dorn.
I should quit while I'm ahead, I think. Thank you very much, Rex. So for the time we have together, I'm going to try to walk you through what we're trying and how we approach transforming healthcare through the delivery of information and data. So really, this is about how can we change care through delivering information, because historically, we've focused on transforming healthcare through the delivery of care itself and also therapies, or what I would say is silver bullets. So conceptually, what I've always hoped for and believed in, what I've spent my time thinking about, is that we should be able to take the best information delivered into the workflow of clinicians or anybody who's involved in an individual's healthcare journey and make it as effective or perhaps more effective in improving healthcare as a drug or a device. So that's where the ground we're coming from. The information we deliver, how we deliver it, has to have a physiological benefit, has to improve care. It can't just be information for the sake of providing information. That's a critical underpinning tenet. So
when we think about transforming healthcare, we take the premise that we're reforming what we call is an accidental system. And in an accidental system means that nobody sat down and thoughtfully organized our healthcare system. And we know that it has been associated with a lot of different negative terms. It's unaffordable, it's maybe wasteful, it's disorganized, and we want it to be improved. We want it to become affordable and valuable. But in that mix, what we shouldn't forget is that our healthcare system has generated incredible brilliance. It's advanced with regards to its technology delivery, and I believe that everybody involved in it is deeply compassionate. So in as much as it's accidental and in as much as we need to reform it, we should think about the fact that there's this legacy of brilliance, advancement, and compassion. And as we take this journey, we need to remember that the accidental health system is significantly impacted by this concept that there are new practices coming out every year. So one of the big challenges is that every year some things that we do are helpful, and then the next year they may not be, or we may have interventions that are not helpful that we'd remove, or we should do new things to patients. So there's a big churn, and that's a real challenge for the entire healthcare system to sift through and sort through. And traditionally, we've let the individual manage that. We've let the individual retain that information and make that judgment. And that individual needs to be buttressed now with the information. That's the premise we're coming from. And I had a professor in medical school who said, we're going to teach you everything you know in med school. Half of it's right and half of it's wrong. We just don't know which of the halves is right or wrong. We can't tell you which. And that's really, in some ways, the truth, is that we do a lot of things we're not sure are clearly beneficial. So that's an undercurrent that's a tension within the healthcare system. But within all of that morass of an accidental system being impacted by evidence churn, we cannot forget that there is one person who's coming to be healed and coming to be cared for. And so all politics aside and sort of the larger macro economic issues, that's our focus, is how do we impact that individual's health journey. And we think there are many different terms that are also being thrown about, but it's really about that care moment. It's not really, people talk about population health and they talk about different types of organizational structures, but we need to remember it's about that individual. But along the way, as we think about that individual, we know that there's this challenge, this tension about the individual being treated by the individual and perhaps not having complete information. And I always like this quote from Galen. He was a Greek physician. It's one of my favorites. It says, "All who drink this remedy recover in a short period of time, except those whom it does not help." And therefore, it obviously fails in only in incurable cases. And this is in my experience, I have the best observational bias. And that's also another thing we're trying to cut through. So as you anchor your thinking about what we're trying to do in the field of evidence-based medicine or in the field of trying to transform care through the delivery of information, we're really attacking these major undercurrents. And to really unpack what we've anchored you on these concepts, to unpack them, I'm going to focus on three trends. One is the pursuit of quality. What is quality? What is quality in healthcare? We all have our own definitions that we bring to quality in healthcare, and I'll try to give you what is really the field's definition of quality. And it's a little bit simplified for those of you who spend your time in here. You might feel that there's more to it, and I agree there is, but for this purpose, I think it'll be one definition. There's a shift in culture, as you've heard. Doctors, nurses, pharmacists, everyone in the healthcare environment is going through a cultural transition, and I'll give you a sense of how that is occurring and how we're dealing with that. And then really try to walk you into the premise that we think a lot of this could be improved through technology and give you a sense for what we mean by that. And we don't mean technology in the sense of a new, very high-cost medication. We don't mean technology in the sense of a new device, but really taking the information we know and is in the literature, making it accessible at the point of care, and then integrating it so I can use it at the bedside. That's what we mean by technology. So in the pursuit of quality, the first thing to think about is really, when we think about quality, we build it around two major concepts. We think about safety and value is really the underpinnings of quality. And the reason in healthcare we talk about safety in addition to value, some might say that value is quality, is that there's a need in healthcare for there to be high reliability science, the idea that there is a very low tolerance for errors. So we need to make sure that whatever we're doing has very low error rate. And then really around value, it's outcomes for cost. Do we know that we're getting an outcome for the spend we're making or for the technology we're deploying? And if you look across a range of different metrics, whether it be national health population metrics compared to other health economies, or you look at really the price of a particular drug versus its health outcome, it's not clear we've really done that comparative effectiveness either at the system level or at the individual technology level adequately. So we'll spend some time talking about that. And then there are a range of different ways that people are putting quality into sound bites, and one of them is the 6 aims for improvement from the Institute of Medicine, and then now that's been distilled down to what is called the triple aim, which was really pioneered by a gentleman named Don Berwick at the Institute of Health Care Improvement. You may have heard of him, and it's better health, lower costs, and better health care. So trying to simplify things and focus on what we can improve in quality. We fundamentally believe that quality is a balance. And the framework here is that the relationship between quality and interventional intensity has this sort of semicircular shape. And you can intuitively think about how this works. In certain settings, more interventions and more delivery of care improves outcomes. And there are definitely places that are underserved where we may need more access and we may need more interventions in care. But we do know that in many cases in our health economy, there's a sense, maybe there's some over-intervention, and we know there are cases, whether it be CAT scans in children and different types of, that there's too much care being delivered, and we need to find a balance from our current state, which we might be a little bit skewed to the right here with regards to interventional intensity, finding really what is the optimal point of balancing interventions and cost. And this is a big ethical question that the health system is wrestling with. And I think that's really where we think the first place to go is to understand what is the actual science and evidence around the cost and cost effectiveness. But in many cases, we don't have the answer there, and therein lies the dilemma and the gray zone. But that's our goal, is to try to bring transparency and organization to this tension around intensity and quality, and to move back to a more optimal state. We also know that we're in a significant amount of cost pressures. The intensity of care and the demographic shifts are really creating a situation of unsustainable costs, and no matter where you are in our country or in whatever you do, we've all heard about the impending Medicare challenges with the baby boomers and the demographic wave. And that will not go away. So we in some ways have to address this intensity cost and shift in how the demand for healthcare is increasing dramatically. We also know that there's significant changing payment models. Many of you may have heard that the way that care is being paid for now is shifting from I get paid for each individual step I take with the patient to now I pay for a specific series of interventions or a particular episode, and there's some value and quality measures. So that's a big change. It's only getting more so. There was a recent announcement by Secretary Burwell that there were 50% of payments from Medicare and some of the federal programs will be value-based by, I think, 2019 or 2020. So this is a seismic shift in how the economics of healthcare are unfolding. And it's not clear that we're prepared for it. So that's one of the things that we're trying to help with and wrestling with, because most of the entire health system over the past 30 years, since really the launch of Medicare and Medicaid in 1965, has organized itself around a pay for every step of care I deliver, or the fee-for-service model. But there's a big movement here. So stay tuned. I think so here there's another major seismic shift, how we're paying for care, the demographic trend. And along the way, there's pressure on the payers to organize themselves. They have specific quality ratings. So there's what I can tell you is that at no time in history in the healthcare system have things been changing this quickly or this dramatically. So for those of you that I have 4 younger children, 1 in high school, who are thinking about future career directions, I have to tell you that healthcare, in spite of everything you hear, is still a fantastic place to spend your career. There's a huge amount of disruption and change occurring, and if you're young and flexible and dynamic, you want to be in an industry that's changing and is not set in its ways and is going through upheaval and transformation, because there will be new kinds of jobs in 5 years, and there'll be new kinds of roles that I can't even predict because it's undergoing change, unlike it didn't over the last 20 or 30 years, much like other industries have gone through dramatic upheavals like media and entertainment. So we need to address the root cause of cost, and we know that 1/3 of healthcare costs are waste, and that we think that how care is delivered is really contributing in a major way to those costs, and we need greater clinical attention to the choices we make. So that's really what we're focused on. The cost side is trying to find those things that are unnecessary. There's a shift in care culture that's going on now. We believe that there's a lot of variability in care still, and there's good literature to show that, although it's improving, and that it's possible to identify a standard of excellence. So we can say in certain scenarios, in certain situations, for certain individuals, we know what is the best practice for care, and we can discern that, and we want to try to really regress or drive to that standard of care through the delivery of information as the patient's receiving care. We think that it's important to know what that standard of care is. We're starting to work on it, and obviously we're doing that at Hearst Health. But a couple of statistics for you here. So there's a good publication that came out that showed that the lag between when a new therapy is identified and when it's put into practice generally can be between a 15 to 20 year lag. So that means that we might know something at an academic medical center that might be beneficial, but for it to be broadly adopted and used in the vast majority of appropriate cases takes a significant amount of time. There's good data to show that the pace of publication makes it impossible for an individual to stay abreast of the literature. So that's where, again, we need to have abilities to digest that information, parse it, and serve it to clinicians such that they don't have to actually read every relevant article. And I already shared with you the statistic early on around the changing practice patterns in nursing or pharmacy or medical practice. This was about 40% of practices change or reversed, or in a sense aren't helpful, which we thought were helpful. And then one of the things that occurs today is that there's a lot of ambiguity. So from U.S. Oncology Task Force, they found that many therapies are similar, and it's hard to tell the difference between them. And then one of my favorite quotes from the British Medical Journal, which says that there's this practice of eminence-based medicine, which is a cultural challenge within healthcare, which is repeating the same mistakes with an increasing confidence over an impressive number of years, and that's we're working our way against that challenge as we get people who are in their practices, sort of stuck in their practice. So what do we need is we need wise standardization, meaningful measurement. We need to continue to evolve scientific knowledge, and then we need to find really these thoughtful exceptions to the guidelines. So it can't be a one-size-fits-all. So those are some of the cultural challenges and some of the approaches we're taking to try to address that, how people will have to change their behaviors to help transform care. And then, so really, how does technology come into play here? We've talked about the issues around cost and quality. We've talked about how we have to change our behaviors and our culture. Well, we think that in some ways technology can do that. And we've had a big start at this, and you've seen it through the stimulus bill and some of the funding incentives that have gone into hospitals and medical groups to adopt medical records. So much like there was automation in other industries, there's been a sponsored automation within healthcare around the adoption of the electronic medical record. And many of you now have gone to see your doctor, and many of them are using electronic medical records. And the genesis of this whole policy movement was a very important paper written in 2005 by the Rand Corporation out in Santa Monica on the West Coast. And they really did some good work that showed that there would be significant economic benefits and efficiencies through the automation by using electronic medical records versus paper. And they made some assumptions. And a couple of the key assumptions were that things would be interconnected and they would be interoperable, and things would be, these systems would be used effectively. And what's happened is we've had such a rapid adoption is we haven't really achieved many of these underpinning tenets of the primary research that launched some of the funding. We don't have as interoperable systems across different venues, so that's a challenge. The usability issues have not been developed as organically as in other industries because there was a rush to install systems, and that has really tied down some of the benefits that we've been able to extract. So right now we're at a very interesting transitional phase where there's been an initial adoption of technology in healthcare around using the electronic medical record, but it's a very early adoption, and there's a whole separate wave that will come about optimizing and making that technology more effective. So stay tuned for that, because that will be the chapter that actually delivers the benefits. It's sort of like we've laid the cable to the different houses and we've put out the cable network, but we really haven't gotten the programming right. That's probably an analogy you could take here. So we're just at the beginning. So what we think is needed over time is continued improvement and maintenance. We need to be able to deliver the best evidence through that electronic infrastructure, and we need to encourage easier adoption and use. This can't be a challenge for the actors in healthcare to be using these systems. So one way to really get at that is to say we're going to connect the different venues and focus on these three rights, which is the right care for the right patient at the right time. And I'll give you some scenarios. And one thing is we think that as the patient goes through a journey, these critical transitions, the key question is where do you focus in this journey of care? We've all spent time in the healthcare system. Maybe not everyone's been to the hospital, but at some level we've interacted with it. And there are different moments along that journey that are more critical in our health journey than others. And we want to identify those moments, and I'll go through some of them now. And we want to inform those moments optimally such that your health outcome is ensured to be as best possible. So here's one example. If we're about to head into the hospital, there's a critical moment there when we're deciding, and clinicians on our behalf or through shared decision-making, we're making a decision about what treatments to get. And that's where there's an ability to deliver the best practice evidence there, both to the patient and to the clinician, such that there can be a good decision made. So that's a critical time. When you're in the institution, you've received care, you've had some kind of intervention, or you're being managed in the hospital, that's a critical moment also. How can we make sure that the right information is in the hands of... So that's another moment we focus on that's absolutely critical. And then as you leave, we all have relatives and family members who, when they leave the hospital, it's ambiguous to what venue they should go. Should they go home? Should they go to a nursing home? They leave, they're put in a wheelchair with a bunch of papers and take a taxi somewhere. I mean, this is where we are today. This type of ambiguity that's a critical moment where we can bring some information to bear to say what is the right venue and how do we ensure that what was decided in the hospital is communicated to the aftercare facility other than through a fax or a phone call, right? That's an important bridging step. Once you re-enter the community, we need to be sure that we're managing chronic diseases. We know what needs to be done in 6 months or in 2 years, and make sure we're keeping up on those types of population health management interventions. And when we're in the home, is there an opportunity for us, finally, to deliver the highest quality care in the home? No, I mean, we all think going to the hospital can be a place to get better, but only for a short period of time. Hospitals are dangerous places. Nursing homes are also dangerous places. So at the end of the day, is there an opportunity for us to deliver more of the care that we would otherwise get in a nursing home or in a hospital in the home? Is there an infrastructure that's available to do that? And that's another focus. So, there's a big demographic shift I talked about early on about the baby boomers moving in and the wave of demand into institutions. But as the cost of care gets pushed up through the delivery of care, it's less costly if you can do it safely to deliver care in other places than in large hospitals and so on. So that's where technology can help a licensed vocational nurse have a checklist in the home. Maybe there's a concept you may have heard of in healthcare that's going around now, which is allowing every professional to practice as what's called top of license. The idea being There may be things that a doctor does that don't make any sense, or a waste that they do it anyway, just through tradition, that a nurse practitioner could do. And there may be things that a nurse could do that a nurse practitioner used to do, and so on and so forth. And there's a lot of tension between professions around that, but practicing atop a license really can be enabled through the provision of the information that allows that individual to make the smart decision. So at the end of the day, we don't want to forget that one person who was coming to be healed in their journey along the way here across these venues. And that's always our focus. And so hopefully, at the end of the day, our goal is to try to impact cost and quality and really make sure that that individual's had the optimal outcome in the most efficient way through technology and information. So at this stage, I'm going to pause now. We'll go to the questions with Rex, and that's your primer on healthcare information technology. And
Great, thank you. Okay, have a chair. That's terrific. This is certainly some provocative thoughts there that I think that was probably my jacket making that noise there. So we recognize that healthcare being a $3 trillion a year industry in the United States, I believe, this makes it both, we have both moral, therefore, and political questions here. One of the things one of the questions I think is raised that you hear often. I remember my family physician telling my family at one point many years ago, a line that we've often heard, medicine is a science, but healing is an art. So is the standardization of evidence-based care a threat to that artistry?
Yeah, that's been a tension, a perceived challenge within our field for years. I would say that the art of care is really the interpersonal interaction. How do I relate to you? Do I look you in the eye? What is my bedside manner? What is that? I think that's been confabulated with my ability to make therapeutic decisions on imperfect information, and I think we need to continue to separate the two. And so I think that you can still have a great art around how you care for people, but still be able to provide some evidence-based medicine or some standardization around that. So I would say that the two are not mutually exclusive. I think they can coexist.
What about the threat to the loss of privacy? Is that something that we need to set aside to get the benefits of more widespread knowledge?
Yeah, I mean, I think that many of you know we have these HIPAA regulations, and that hopes to protect us from some of that. But there's always risk, just like there were retailers like Target around the loss of privacy. But with regards to informing the actual care journey or the individual, that can be done in an anonymized fashion. So you don't need to, you really don't need to get at a lot of private information to do that.
But in delivering to individual patients, you do. You would want access to that data in the hands of every clinician.
That's correct. So when you're using the electronic medical record, absolutely, you're in a very privileged environment there, and you have access to private information. But that was still the case even when we had paper-based records. And people forget that, go back 20 years and you could, the records were behind the receptionist.
There we
you could easily, go in and the record could be photocopied, and so charts were lost. And so there was a lot of sort of, I'm not sure the information was any more secure back then or is less secure now. Actually, it might be even more secure. So, I think people forget that the information could have been accessed easily on paper.
Yes, that's true. Maybe we're just more sensitive about it these days because we hear about the privacy breaches at Target and so on. It's just a higher visibility. Well, so price is often where, cost, I should say, of healthcare is often where we, in journalism, cover it because we see the battles in Congress. I'm quite interested in the fact that I understand in January of this year, hospital prices were seen to drop for the first time year over year. January of 2015, it was less expensive than in January of 2014. What's going on?
Yeah, I think that, Jim, we'll put that on you. But I
That's a
will
good
take
thought.
my stab, and I think it's market dependent, and it has a lot to do with concentration and competition in different markets. But fundamentally, I think that there is a moderation in prices, you could say, because there's a change in how people are making healthcare, slightly making healthcare decisions, and I think the payers and that the leverage between the payers and the hospitals is shifting. But I don't know how sustainable long term that is. That was an interesting metric, but we need to see the next couple of years to see.
So I'm speculating that the higher deductibles that a lot of us are paying might be discouraging.
Yeah, I mean, so the textbook answer would be, we have exchanges, we have high deductible plans, bronze, silver, gold, the bronze and the silver. People are being more cost conscious about their purchasing and thereby, negotiating prices more aggressively with hospitals. That I don't know if that's actually the cause. I don't think anybody's really connected the two. That would be the intuitive sort of view, but I don't know if the data actually connects the two yet. Or if we've had enough folks in the marketplace with high deductible plans to really impact those costs over a long enough period of time. That's that sounds like a really good storyline.
Yeah.
I just don't know if the economics, the causal economics are there yet. That's just mine.
Interesting. And once we all have high deductibles, we'll get inured to the cost anyway, and we'll get access to it again. We'll be accessing more again. What about this notion that we do know some of the activities that high quality, low cost medical practices share? There's this research that has shown that there are certain practices that we know to work. So if we know that, how do you get it across to people? How do you get wickedly independent physicians to do things?
There's an interesting argument, you were talking about the modern healthcare, that there are there's low cost, there are best practices out there about how you can deliver care. And I think we're working on extracting those, and I think it's really evidence-based medicine. You're doing evidence-based guidelines and a few other interventions. And they've been able to identify that these high-performing, low-cost medical groups are out there. And what's exciting about that is it tells us that there is a way to deliver higher quality cost at higher quality care at a lower cost. And the reason that's important is that for about 10 years, I would say, from 2000 and on, there was a big debate about, does high quality care reduce costs, or does high quality care increase costs? And that's been a tension in the field for a while. So now this preliminary research is starting to show that you can have very efficient producers at the medical group level, and there's some best practices there, and that's encouraging. So we need to take those and we need to proselytize them through our systems and make them more standard.
And do you have a system that will do that? Is that one of the things that Hearst is delivering?
Yes. That's
excellent.
Right, that's a setup. But, one of the practices are evidence-based best practices used within the medical, and that's what we do essentially. So it's very much of an endorsement of our independent endorsement of what we do. But there's been a lot of science along the way about the benefits of what we do.
Well, let me bring up our three other experts here, and we can widen the conversation a little bit. Let me introduce first, and if you'd each take a place at the table as I bring you up, Dr. Reed. Come on down, as they say. Dr. James Reed is, in October of 2012, became the first person to hold the newly consolidated position of President and CEO of St. Peter's Health Partners, our region's largest healthcare provider. He was previously the President and CEO of Northeast Health. And of course, St. Peter's Health Partners, was formed by the merger of St. Peter's Healthcare Services, Northeast Health, and Seton Health. So Dr. Reed has an MBA from the Wharton School at University of Pennsylvania and earned his medical degree from Cornell Medical College in New York City. Denise Gonick, CEO and President of MVP Healthcare for the past, I believe, 3 years, after previously serving as MVP's Chief Legal Officer. Before turning to the healthcare industry, she practiced public sector labor law a graduate of Hearst University and the Albany Law School, and Dr. Michael Branigan, born to a Japanese mom and an Irish-American father. I bet there's some stories about this. And he grew up in Newport, Rhode Island, completed a master's degree in religious studies and a Ph.D. in philosophy at Belgium's Catholic University, Leuven. And he holds the Pfaff Chair in Ethics and Moral Values at the College of St. Rose and heads the Albany Medical College's Alden March Bioethics Institute. So, you know, a doctor, a lawyer, and an ethicist walked into a college. And what do they do? Let me see. Why don't we just start, Dr. Reed, with you, and tell us, give us just some thoughts on what we've been discussing today on these notions that you've heard here.
Well, my first take-home lesson is that since St. Peter's Health Partners uses, if not each one of those companies listed up there, most of them, if we lose any information, I know whose home phone number to call to retrieve it. Well, I guess let me just pick up on where Dr. Dorn ended and your conversation on this whole cost-quality thing, because this is where, for many of us who are sort of on the front lines of providing care, this was an epiphany. If you go back to the 1990s, mid-90s, I was a primary care physician and I was seeing patients. And remember, that was the era of capitation. You know, we would give the docs a certain amount of money to take care of you, and then the monkey was on our back to do it cost efficiently and also to have great outcomes. And sure enough, the cost curve in healthcare flattened. Everybody, you know, we talk about healthcare's been going up, and finally hospital costs leveled off. They leveled off in the 90s as well, when we had capitation and when we had, remember, the gatekeeper. We primary care docs were the gatekeeper, and Denise would deny the MRI that I wanted for my patient, or whatever the case might be, and costs leveled off. But most of us at that time believed, you know, what happened was, why did the lid come off? Why did costs take off? Because most of us at that time, most of us as customers, as patients, started to think, well, wait a minute, if I'm having fewer MRIs, then I must be having less quality of care, right? If I have weakness in my right lower extremity, shouldn't I get an MRI, doctor? And if I don't get it, then that's low quality care. And we had this equation that somehow, if docs control costs, then they're diminishing quality of care. So we don't want to have anything to do with that. So the payers, who were the bad guys, everybody was shooting at them, finally got pushed in having to get rid of this whole idea of prior approval and us as gatekeepers and everything, and said, nope, you're approved, go ahead and get the test. And what happened? Costs took off. The big eye-opener for me is that on the front lines then and the front lines now in providing care was the data that Dr. Dorn's talking about started to not only say, as Dr. Dorn did, that you could have groups that had low cost and high quality, but the real scary part of the numbers was, in fact, it looks like they were directly related. That it wasn't just an association, but in fact, if you practiced high quality care, in fact, you would wind up with low cost care. And that was the one that sort of started to say to a lot of us, we better get on the stick here looking at this data, because we can't hide behind that veil anymore. And we've got to be doing both more cost-effective care as well as higher quality care. And we didn't know that until firms like Dr. Dorn was talking about and so forth started to provide this data and started to provide it on the front lines of care. We have systems now that if I'm a primary care physician, you probably know we've had a St. Peter's and Ellis Medicine formed a new venture that got approved as the first accountable care organization in this region on January 1st. And we have software that we're going to be using with the physicians and the hospitals and so forth that literally will say to me as a primary care physician, you know, Dr. Reed, you've got these 10 patients. They are your most expensive patients. And the reason they're your most expensive patients, you're missing there are gaps in the care that you're giving them. Might be a diabetic, might be an asthmatic and so forth, and you're slipping up. Now, when I used to practice, I didn't have that kind of information. But now I can focus right in on my 10 most expensive patients and say, well, maybe one of them needs all those tests. They got this very bizarre illness and we need to do that. But I'll bet you 9 others are because I forgot to do this or I didn't do this. And if I do those, in fact, the cost of care is going to come down for those individuals.
And that's what these systems are giving us. Now, I'm a believer in IT and healthcare data. So when I go to this next point, I want to remember that, okay? Keep that in your mind, please, because I wanted to tell you, for those of us in the front lines, why would we be anything other than totally embracing IT and data? And I just want to share a couple of our concerns about these, and Dr. Dorn actually hit on them or alluded to them, but I want to drive them home a little bit more, because you remember Luke Skywalker, and there's the dark side of the Force, and well, there's the dark side of the Force here a little bit that we need to work on. We're working on it. It just needs to be fixed. And so let me just outline two things. Anybody want to guess? So St. Peter's Health Partners. Anybody want to guess how much we spend on IT per year? I don't mean on capital costs. I don't mean on buying a new IT system. If I didn't do anything more with information technology, just kept our current system, paid for the maintenance and the license and my IT guys, anybody want to guess what we pay every year just to do nothing else, stand still? $65 million a year. St. Peter's Health Partners, we're only one healthcare system in the region. $65 million a year for IT just to kind of stay where we are. Well, if IT were costing me $50,000 a year, I would say I can find $50,000 a year for the kind of results that we're going to get from that information. But here's the problem in healthcare. It's not $50,000 anymore. It's $65 million. And I know from other studies that if I took 30 million of that and put 20% more nurses on the floor, I, in fact, would improve the quality of care. I'd reduce the number of UTIs. I would reduce the number of GI bleeds. We have lots of data by doing that. And so the problem for us in healthcare right now is this pie is getting more and more fixed. I've got to rob from Peter to pay Paul. And so let me ask all of you, you've got $10 million, you're in my job, you got $10 million to spend, and would you spend it on IT? Would you spend it on putting more nurses on the floor? Would you spend it on robotic surgery? Well, the correct answer, pardon? The correct answer to my question is we don't know. And that's the problem for us in healthcare right now is we know that if we do more with IT and data, we will improve quality. But to do that, I have to take the money away from something else, and that diminishes quality. And I'm saying this to the academic community because you got to help me out here. I don't know which of those I should choose because no one does the simultaneous equation. We do them separately. If I spend it here, it's an improvement. If I spend it here, it's an improvement. That's not my question. My question is, if I take it away from here and spend it here on daycare, or whatever the case might be. And that's the answer I need to know in the front line of healthcare right now for IT and data is, what is it? What's the other side of that equation? Because I want to spend it, but I know I may, in fact, be diminishing quality since I never measured the other side of the equation. So we need to do that. That's concern number one. Concern number two, and Dr. Dorn alluded to it, and it's one that we're working on and is crucial. I've had actually this conversation hit home several times lately. I have somebody on our senior staff who was making the point. He says, my mother was in the hospital, and when she got out, she commented on, do you know how much time those nurses spend at the computer terminals now? And yesterday, St. Peter's Health Partners, its quality committee of our board of directors met, and I had one of the most distinguished physicians and business leaders in the region was sitting next to me, and he also was one of my clinical professors when I was an intern, and he said to me, Jim, I was in your hospital twice last year. I couldn't sleep one night, and I was watching one of the nurses spend literally 2 hours at a computer terminal entering data. So here's our problem in healthcare. I need that data. If I don't get that data, it's very hard to improve quality. However, in order to get that data, what I'm basically doing is telling all these people who came to healthcare because they wanted to do something for somebody else. Dr. Dorn made the point, the very apropos point about compassion. We're asking them to basically take time away from that bedside and spend it on gathering that data for us. And it was interesting, I had my appointment with my family physician. My family physician retired recently, so I had my last appointment with him. And remember, I'm a a VIP with him. So instead of getting the average of 6 minutes with my primary care physician, I got 15 minutes with my primary care physician. And he had his computer, his laptop with him. He walked in. We knew it was the last visit I was going to have with him. He asked me the question, put it in, and I measured him. In the 15 minutes that he was with me, he looked me in the eye 3 times. Yeah. And now I know his problem, and I want him to collect that data. I really do, because that's going to make my care that much better. But that's the problem we're facing on the front line of healthcare right now. We need this, but we don't get it free. We don't get it free in terms of dollars, and we don't get it free in terms of the compassion. And it's not the patients I'm worried about. We're giving them great care. I'm worried about the people who come to work in healthcare, who want to express that compassion, and we are pushing that often to the edges. So we're doing things to try to solve that, because we need that data. For instance, we're using scribes who actually go into the office with the doctor, so the doc can do that eye contact, the scribe does the other, and in fact, it's working very, very well. The patients are happy about it, the docs are happy about it. But so I would just say on our side in the front lines, we do need to understand, A, that cost, what is it we're taking away from, and how do we actually balance that equation? And secondly, as Dr. Dorn said, how do we keep that compassion in healthcare? And we're actually trying out systems aimed at improving the compassion in healthcare and allowing healthcare workers to do what it was they all wanted to do, which was to do something for somebody other than themselves.
That sounds like a great way to, it actually does sound, it fits in with the point you were making at the very end about practicing at the top of your license, because it seems to me like the scribes might be at the top of their license if they're doing the data entry, and the nurses would be at the top of theirs if they're doing patient care. So I'm trying to hire people to design pages who are not actually copy editors, because copy editors are more expensive. And I'm thinking, you know what, I don't have to hire a copy editor to actually assemble a page. So it's not quite, the consequences aren't quite as high as if you've got a doctor or a nurse practitioner, but it does seem, and that I thought might be actually a good entry for an insurer, because it does seem to me that the choices of who does what may at a certain level be governed by decisions made at the insurer level. Is that true?
I think part of what we're seeing and experiencing now is that with all of this, it's much more of a shared responsibility than perhaps it's been in the past. So I think one of the many things that's different between the capitation era, for example, and now is the existence of data and the transparency that comes along with it, in addition to all the regulatory changes that we're so focused on. But it strikes me from the insurance perspective that one of the big challenges we have is how we can use all of this data that we have and actually turn it into actionable information, and what are the specific milestones that we have where we can do that. So one of the ways that we look at this as an insurance company is to be able to try to understand some of the trends that we see in our populations. So a very classic example would be overutilization of the emergency room for non-emergent conditions. And there's a lot of things that come to mind for that. Sometimes there's a thought that, well, if their doctor's office was open outside of regular hours, if it was open on the weekend, perhaps people would be more inclined to use it. And through the use of data, we had 2 different experiences. One, in the capital region, we found that actually was the case, and we worked with our physician partners to examine what was happening based on the emergency room utilization reports, and saw that in fact people needed more access than they had to be able to get to the doctor's office during those non-regular hours. In another part of our service area, down in the Hudson Valley, and for another part of our population, happened to be the Medicaid population, we found that that was not the case. That in fact, usage of the emergency room was peaking in the middle of the day, and the doctor's office was open. So part of what you had there was an education and communication issue. And we find that is really often at the crux of this, is figuring out who is engaging in that kind of behavior and why. And what we were able to do there for the Medicaid population was to work with the physician community to actually talk to those patients and help them understand how they could in fact get the same kind of care, more appropriate care for them at their offices. So that was very helpful. For us too, when we think about quality from the insurance perspective, we get measured for quality depending on the type of insurance that somebody has. So the government actually sets forth for Medicaid and for Medicare very specific quality measures. CMS puts out a STARS program for Medicare, and we happen to be a 4.5-star program, and that gives us very specific criteria that we're supposed to meet. Likewise, for Medicaid, the state of New York puts out they call it a quality incentive, where they're trying to get you to engage in certain kind of behaviors, and they're multifaceted. That's one part from a pure service perspective, it's what am I doing, the health plan, to engage with my members to help them understand that they should go for their well visits, that they should get their vaccinations, that they should get their mammograms, things like that. But it's also engaging with Jim's area and making sure that the quality of care that's rendered is given according to certain standards. And then meeting certain customer satisfaction standards as well. So I have the government measuring me to make sure that I do all that, and then paying me accordingly, either paying me more based on how good a job I'm doing or penalizing me. We don't have a similar system in the commercial payer space, in the commercial private pay space. We have an independent, what we call NCQA, third-party reviewer, that will look at and examine a lot of those things, but doesn't necessarily translate into an economic incentive for me as a consumer when I'm choosing my health plan, for example. One way that this, I could give you an example of how this is played out in a good way, would be for breast cancer screening. So we can look at and break down, in the case of some of these scorecards, what those requirements are, and have done that for mammography. And if we see lower levels of women getting their mammograms than we should, then we can drill down into that and say, well, why is that? And I have to say, in some cases, the kinds of interventions that we use, this maybe goes to the insurance version of compassion, right? We may not be able to look somebody in the eye, but we have representatives that will get on the phone with those members and say, let me help you make an appointment. Let me help you get there. Did you know there's this mobile option, or that your doctor in these places right here, you can do that. So we can influence it that way. In that example, we were able to do that effectively, and we saw a very distinct increase in the number of women that were getting those mammograms that ultimately led to a much higher score overall for us on our scorecard. And then I think, the other piece of this that we're all talking about is, how does it affect me as an individual, as a consumer, whether I'm a patient or I'm not a patient? And so Jim talked about the MRI experience, right, from years ago, where maybe health plan might have said, okay, no, we're not going to authorize it. We don't do that anymore, right? And I think that's a good thing that we don't do that, but patient is much more engaged, right? So now, if they tell me I need an MRI, I, as an insurance company, need to be able to provide the tools to help that person understand where they can go and how much it will cost them. Because now we're done with the world of co-pays for the most part, and we're into the high deductible world, where that's going to cost me a certain amount of money, and maybe I never would have thought about before. But I have to think about that now. And so that's why, in my mind, all of this is a shared responsibility. And to me, the good part about that is the more we engage in these discussions, and the more we perhaps redefine who does what and experiment with that, I think it's another opportunity to take cost out of the system. The more that, for example, can be done by the provider that perhaps used to be done by the insurance company, that's something I don't have to do and I don't have to pay for. And that's good. That moves us to a better outcome. So I'm optimistic. I don't think this is going to get solved immediately. I think it's going to be a continuous learning process. But I think that the amount of change that we're seeing is actually very exciting.
Terrific. Well, now I'm really anxious to hear from Michael Branigan. The part of his biography that I failed to include is that he's a Times Union columnist as well. So ultimately here we are talking about protecting human health and preserving human life in the context of not spending too much to do so, aren't we? That's a very uncomfortable conversation to have. Maybe you can tell us where we begin to draw the line.
First of all, is this on? Can you hear me?
Maybe we can crank it up a bit.
This is very uncomfortable. How do I do it? You know, it's very dangerous to have a philosophy. Because this conversation, the language is very alien to us philosophers. We deal with the abstract. It sort of reminds me of my grandfather when he found out I was going to study philosophy. He was Irish. He was always involved with his Irish quips. He said, you know, Michael, you never plow a field, but you turn it over in your mind.
Huh.
So you're the ones plowing the field, we're the ones plowing it over in our mind. But there were so many great questions that issues raised. And Rex, you're absolutely right. I think the juggling that physicians often encounter is taking the incredible amount of data they have and applying it to a single individual patient. It is flesh and blood. Data, they're numbers, they're abstractions, they're measurements of the real. And there's nothing more real than a flesh and blood patient. And I think that is the challenge that a lot of physicians have. I don't think anybody here would disagree that there is no dearth of data, no dearth of information. We have such an information glut today. Googling contributes to that. Patient finds out he has a particular condition, let's say hypertension or pre-hypertension, right away Googles it. And then encounters a million hits, and the most popular ones the first few pages, of course. So the patient comes to the doctor with all this data. The doctor himself is reading all kinds of serious articles, journals, hopefully, regarding hypertension. And we have all this data. One thing we don't have enough of, especially doctors, probably the most important component, is time. So how do you juggle the deficit of time and the excess of data in this incredible data utopia that we are now living in? We just have so much data at our disposal. How do we interpret it? And I think that's one of the issues, the interpretation of data. Now, I mentioned my grandfather. He did not become an official philosopher, but he was very philosophical in his approach. And I think we often learn a lot about things from those who aren't the experts. One of my favorite scientists that I often read was Stephen Jay Gould. He was diagnosed with abdominal mesothelioma at the age of 40. Which was then the 80s, a rather lethal disease. Now treated, thank God, because of the provision of data and good evidence-based medicine. But then it was rather difficult. But from what he read, because he's a scientist, he read that there's an 80-month survival mortality rate. Rather good news. 40 years old. But then he read between the lines, realized that the study was about median survival rate. And a lot of the public don't know the difference between mean survival, or average, and median survival. So they'll read the statistics, and Mary speaks this much better than I can. But you read the statistics, and most people who read that will say, well, I'm going to be dead in 8 months. But not Stephen Jay Gould, because he knew that median survival meant that half of the people who have this would be dead in 8 months, most likely. But he placed himself in the other half. And he wrote a brilliant article. It's worth reading. I'll mention it. It's called "The Median Isn't the Message." The median isn't the message. To me, I learned a lot about statistics in just that one article. because he made it clear what the median is, and how to read statistics. However, Stephen Jay Gould is a brilliant scientist, paleontologist, evolutionary biologist. Most people, when they read statistics, I think a lot of them cannot understand the statistics. And I think one of the challenges doctors face as well is trying to interpret the data. And how can they do that with the little time they have at their disposal? There's so many challenges. So many challenges. And how can the public distinguish between, for instance, statistics based on good science and a sales pitch? Take the marketing of drugs as a good example. In fact, when my next article, this Thursday, my next talk,
Excellent.
I talk about medical statistics. And I talk about in the 80s that there was a new osteoporosis drug, adrenaline, sodium, and it was branded by
GlaxoSmithKline.
Right, thank you, and called Fosamax. And right away the media got into this, that after a major study revealed a 50% reduction for the subjects who took Fosamax, as opposed to those in the study who did not. And that's pretty big, 50%. So there was this full court press regarding the media touting Fosamax, targeted to younger women as well, even though the study subjects were older women who had already had some vertebral traction, so already higher risk. But then when you read into the study further, it turns out that half of the subjects who took the Fosamax, of the 600 or 500 or so who took that, 1% had a hip reduction, had a reduction in hip pressure. Those who did not, there were 2%. You see? So you go from 2% who didn't take the Fosamax to the 1% who did. That's a measly 1%. But it's true. 1% or 1 is 50% too. See, so you have the use of statistics. Now, does the general public know this? And I think that is also a challenge that we have as health professionals, as in whatever line of work we do, that to ensure that there's more clarity regarding the degrees of benefit as well as the degrees of risks regarding proposed new treatments. And it's all about reading the numbers, right? The human mind naturally seeks pattern. But we want to make sure that they're the right ones. And we have to help them. We have to help them that. So healthcare reporting, medical journalism, is a very crucial field. And I think there needs to be more attention to perhaps educating or setting guidelines for healthcare journalists in terms of how they report new treatments and findings. Anyway, that's just the tip of the iceberg of the issues. The bigger issue, one of the biggest issues, is informed consent, which I won't broach now. All this is part of that. So that's the starting point.
That's the starting point. All right, thank you, Michael. Let's turn a little bit to questions from the audience. We promised that we would let some thoughts arise from those of you who've been patient and sitting here. Anyone have questions you'd like to? There's a microphone. Bring the microphone right down here, please, to the third row off here. Thank you.
I'm Mary Ann McLaughlin. I do teach mathematics. Michael referred to me. The first panelist gave nonverbals when Michael was talking about Stephen Jay Gould. Would you speak to that, please?
My nonverbal was just, I've read a number of his books, so forth. I think he's great. Some of them. No, I mean, it was more nonverbal of recognition, and I think he's a very bright individual.
Elsewhere, questions from the, okay, right back on the right aisle here.
Hi, I'm Stephanie Bennett. I teach sociology and public health here at the college. And one of the things that I talk about a lot in my classes and try to emphasize is the fact that in other cultures, when they talk about quality healthcare, they're not always talking about the big MRI. They're not always talking about other stuff. And the countries that seem to do better than us in the quality cost comparison are countries that really emphasize the primary care and the high quality of primary care, which at some points eliminates the need for some of the other extravagant medical diagnoses tests or the treatments, because you've caught the disease before you've prevented it from happening. And I want to know, where does this data that you guys are talking about, because you've been talking about it very kind of, the example was a hospital visit, where does this fit in with preventative care?
Yeah, I tried to, I maybe moved through that too quickly, but you're absolutely right. I think that getting, and this gets into what Michael Branigan was saying and also Jim Reed, that we don't have, we've done a lot of incremental technology development for very marginal clinical benefits, 1% over 2% TPA. I could give you a number of, and that's just how our accidental system has evolved. I think there's a shift now, and Jim talked about it with regards to population health and thinking about what do I do around asthmatics, what do I do around diabetics, and that's occurring now because of this shift from fee for service. We were paying for interventions in our health system. We have to recognize that's how it was organized. And now we move to fee for value and being paid for the outcome of a person over a longer or even a population. As that shift occurs, you have to discern between, you have to make the cost quality trade-off, or not trade-off, but the technology trade-offs in interventions. Other healthcare systems have already made that because they're not in a fee for service setup. So I think it has a lot to do with the economics of how the system has been paid for the past 30 years. There's a recent article, I think, in the Wall Street Journal where there were they were sort of debating about whether fee for service was good or bad. And I think that argument is no longer worth having. I think it's clear where we are. So I think as you move to population health and you have more of a payment for a fixed time or a longer period of time, you'll see clinicians, I think making the different choices, which I think will help. But you also need to be able to identify the interventions within the high-risk populations. So you need the data there to say, I can stratify my diabetics, I can stratify my COPD patients, and I know every 6 months I need to do certain things. And that's where what we do comes into play, and it's really about that circumscribed population. And that will happen, I hope, I think it'll evolve in the next 5 to 10 years, is what I would say.
Did I also understand you in that regard to say that there's typically a 15 to 20 year lag between awareness in a laboratory or in a research setting of best practices and its widespread adoption?
That was a paper that was done in the early 2000s, and I think it's contracting because now we have, our field has advanced a lot, but I think there was some good data to show that, we knew about certain interventions and that not the majority, less than the majority of patients who were eligible for a beta blocker and an aspirin on admission, but a range of things weren't getting it, and that's when a lot of the quality measures came out. But I think in some cases, through the under-penetration of basic best practices and the over-focus on some of the more advanced technologies, that's contributed to that sort of lag in adoption.
Yeah.
Just a couple of observations on that question about primary care, preventative care, and so forth. And remember, coming from someone who devoted, I'm again a believer. However, 2 random observations. I was on a panel with physicians from England at one point, and one of the physicians brought this up because they devoted tons of money to preventive care and so forth. And I commented that primary care physician, we ought to do that. He said, have you done the cost analysis on that? And I said, well, what do you mean? He says, I mean, it didn't work in England. I said, what do you mean it didn't work? And he says, well, remember, preventive care, all your money is up front, and all your payback is years and years away. If I keep an asthmatic out of the hospital, that's near term. But if I prevent their cardiovascular disease, that's years and years away. And what England ran into was, how long can you keep paying this upfront stuff, betting on the come, okay? That was observation number one. Here's an observation number two. In the most prestigious medical journal in the world, the Wall Street Journal, it was noted, and this was got to be over a decade ago. They ran the numbers, and our efforts to the place where preventive medicine has really had an impact has been on cardiac disease. I mean, there's just no question we've really done well on that. And they were making the point that we preventative primary care physicians were in the process of bankrupting the healthcare system. And the reason we were bankrupting it was, if you don't die from cardiac disease, what do you most likely die from? Cancer, right? Which do you think is more expensive? Someone who dies when they have a heart attack or someone who's dying from lung cancer? And it's a huge difference, at least it was in their numbers. And they said, well, we can all pat ourselves on the back that we're doing so well in cardiovascular disease. All you're doing is teeing up the US healthcare system to come apart at the hinges as soon as all those people start having their Alzheimer's and their cancer, and you don't have the money, United States, to afford that kind of care. And you're going to have to, at that point, start denying some of those people the care they're going to need at that point in their life. So, not to be the bad guy, but just want you to preventive care. There's two sides to this equation.
There's an end-of-life care issue there that confounds it a little bit, because it depends how intensely you treat at end of life. But you're right, the mortality, cardiovascular mortality, oncology mortality has crossed over cardiovascular mortality in the past few years, and that's a big shift. But I think I'm going to be more optimistic in that I think if you manage end-of-life care well, and we think about the trade-offs of, do we really want to do, and people make informed choices about how they want to live the last 6, 12 months of their lives in their stage 3, stage 4, and how intensive we are in that phase. I think there's an opportunity there to manage that phase in someone's life with dignity and grace and compassion.
Wouldn't it be just less expensive if the insurance industry got behind political efforts to ban soft drinks, handguns, and cigarettes?
Come on. So now we're
just
the
to be
good
politically
guys, is that what you're
provocative.
saying? I mean, I think actually, though, there's a legitimate point there about, for us in insurance, when you think about what actuaries do, actuaries like slow and steady and consistent information over a period of years from which they can predict what's going to happen next. The challenge with all of this is making good decisions on the good parts about, okay, certain preventive activities should lead to a better outcome overall, and balancing that against some of the innovations which may not pan out. And somehow making that connect into a reasonable and affordable insurance premium is the trick. And I think, there isn't going to be any magic solution to it. We just have to keep at it and get better at predicting.
Mm-hmm.
But we certainly would agree in the insurance industry that we do try to do our best to encourage healthy behaviors as much as possible. And I think that speaks to not just the primary care and the well visits, that's the whole social rubric that we all have, how much support you have at home, the way you live your life. All those social influences significantly impact our health.
Mm-hmm. Okay, there's another question out here, and then we'll have to, yes. Just hand the microphone there for the cameras to pick it up.
We've been talking a lot about physical aspects of health, and I just was wondering about behavioral health, mental health, autism, drug and alcohol abuse, substance abuse, all of these aspects, and how you translate some of your work in IT to that area.
Yeah, no, I think the big discussion now is the mental health parity, and social determinants of health have a huge component that is mental and community-based. That is another big part of the equation, and to be honest with you, we haven't quite waded into that yet with regards to what we do. We're trying to really focus on the physical determinants of health at this stage and trying to get at those. But I completely agree with you that that's a significant component of the larger picture. And I think the first step is really helping with getting to the mental health parity and access, and allowing people to really get treatment around some of these issues, and helping cover some of those treatment that are required. But from where we are today, we're really still focused on the physiological determinants of health.
You know, I hate to say this, but I promised to wrap this up at a certain time, and we are at that point. And so I'd ask you, Greg, just to see if there is a role, if there's something that you would suggest to non-medical professionals, citizens, concerned citizens in this room, that you think would improve the quality of health care, the access and affordability of it. What should we be thinking about?
I would say the first thing is to disabuse yourself of the idea that more is better, that's for certain. And then also always ask the question is, do I really need this intervention? Do I need this, whatever's being recommended? And that's okay. You're not going to offend anybody or any clinician in today's day and age by asking them, do I really need a chest x-ray, or do I really need an MRI or a CAT scan? Or, that's it. That's, I think, if you can do that and inform yourself, I think you'll bring an important counterbalancing, self-deterministic component to the healthcare system that's missing today. Our healthcare insurance used to be selected by our employer, paid for by our employer. We deferred all our decisions to the clinician. That's the past, and we're now we choose our own healthcare insurance. We have shared risk in it, and we should be also making the purchasing decisions and being informed, challenging purchasers of that healthcare. So that's what I would say.
All right. Gregory Dorn, Michael Branigan, Denise Gonick, Dr. James Reed, thank you all very much.
As we bring this third annual William Randolph Hearst Lecture on Innovation in Communications to a close, I want to again thank you all for coming. Thank George Hearst for being here with us. I want to especially thank Dr. Gregory Dorn, Rex Smith, Dr. James Reed, Denise Gonick, and Dr. Michael Branigan, all for engaging us in a thoughtful and thought-provoking discussion about the impact of data on the quality and cost of health care. I now invite you to please join us as refreshments are served and for further discussion on these topics. And again, thank you for coming and good evening.